So we have 201, actually 202 now, so we'll get started. I'm excited. This is our first meeting for 2025. We got a good crowd in-house, and I know there's lots of people online. Do you want to see if we have a quorum?
All right, so we'll call to order, and then if you're present, please just let me know. Julie Freeman.
I'm here.
Okay, she's online. Kelly Roker is here. Rama Stevens. We don't have her.
Is Ashley here? There's Ashley.
And there's, okay.
Yeah.
Okay, good. And then Kelly Vaughn is here. And then Crystal Smith. I know that she's online as well. So, Madam Chair, we have a quorum.
Crystal, if you can hear us, can you speak?
I am here.
Crystal Smith?
I'm here. Can you hear me?
Okay, thank you.
Good, thank you. And then do we have a motion to approve the minutes from the November 20th meeting? Kelly has moved. Do we have a second?
This is Brooke from Emmanuel. I make a second motion.
Brooke. Okay, thank you, Brooke. So it's been moved and seconded. Any concerns or questions, discussion? Okay. Pending that, we'll consider the minutes approved and hand it over to you, Madam Chair.
Do we have anyone new? This is in the room that this is their first meeting, that they never attended GCTE. Anybody new that would like to come and introduce themselves to us? Oh, somebody's pointing. No? Oh, okay. Well, welcome again. What about anybody online? Anybody new online that can introduce themselves to us? Tell us where you're from.
My name is Bethany Chapman. I'm from KJTC. I'm the new Chief Operating Officer of the Trauma Consulting Company.
Welcome. Anyone else?
Hello, my name is Courtney Heron. I'm the new trauma educator at NGHS.
Welcome.
Hey, this is Shauna Baggett. I'm the new trauma registrar at NGHS.
Shauna, you're not new yet. Welcome back, girl.
Thank you. Good to be back.
Shauna, your reputation precedes you.
Oh, I miss my trauma peeps.
My name is Jason Radford, trauma PI coordinator here at Piedmont Henry.
Welcome.
Hey, this is Brett Buhner. I'm the trauma program manager, setting up a new program at Piedmont Augusta.
Glad to have you. Anyone else? Okay. So the first thing on our agenda is our LifeLink update with Kim and Chuck. If y'all could come up front, please. Yeah, back seat. Here. I know. Y'all are so snuggly up here. Ooh, it's sideways. This is confusing. I'm gonna turn a little bit. Hey, everybody. Oops. I feel like it's gonna flop right now. All right. So first of all, I do know it's February. Sorry about that. We put these slides together right at the very end of January, so apologies. But I am Kim Codman and Chuck Massey. Together, we manage our internal trauma work group. So you guys are a super important group to us, and we are always thankful to the committee and the Trauma Commission for allowing us space to come and share some information. We're going to give a little bit of data to start, and then we wanted to have a little bit of discussion about the information that you're tracking for donation and if we're doing it as effectively as we can. So apologies, this is small, but they have copies of this somewhere, right? Perfect, okay.
It was sent out with agenda.
Just. Oh, okay, sorry. There, because I keep having to turn my head to see what, okay. Just so you have it. Perfect, I'm gonna go over here then. So I can read these slides. So this is data from the Scientific Registry of Transplant Recipients, which is actually, it says recipients, but they track all information about donation throughout the state, throughout the United States. And I just pulled, GALL is Lifelink of Georgia, that's our service area, and the United States. And this is 23 versus 24. And this is their cause of death page. And we're gonna talk a little bit more about like how we designate what is trauma in our world versus yours. But the primary causes of death are anoxia, stroke, CNS tumor, head trauma, other and unknown. So as our sort of baseline marker, we use head trauma at this level. This is cause of death. We also talk about mechanism, and again, we'll talk about that in a second. But probably 95% of the patients that go on to become organ donors do fall under head trauma in some capacity, because it does capture gunshot wounds, blunt injury, that sort of thing. So we do have anoxic as grown as a category, and we do sometimes see a trauma that falls into that, so it's anoxic secondary to some other mechanism. But again, if we're focusing primarily on head trauma, you'll see this is so fiscal years through the end of June in 24, we went from 27% of all of our donors, 27.5 coming from head trauma, to 25.1. In the United States, 23 was 22% and 24 was 20.5. So we've seen about a 2% decrease as a percentage of all of the donors. I'm going to explain what that means a little bit more in a minute, but both nationally and at the Georgia level, there was a decrease. But I think the other thing that's interesting to note is that about 5% more of all of the donors from our service area are trauma patients versus the rest of the country still. Again, no one can read this, I understand. It's in there if you care. But again, I just wanted to look at this mechanism, and do I have a pointer on here? Let's see. Oh, look, there is one. It's so tiny though. So the third line down is blunt injury. Again, most of our head traumas. And this is kind of a 10-year span. So across the United States, we had about 1,800 donors from a blunt injury cause of death. And in 2024, it was 2,400. So certainly an increase overall, but we did see a decrease from 2,599, so 2,600 down to 2,400 in 2024. For us, 2023 was a pretty significant year for trauma. Oh, more toys, yay. All right, awesome, thanks. So just kind of setting the stage to give you the numbers, I think one of the things that jumped to our attention, and this is kind of a strange group to say this to, but you know, trauma was down and that was concerning for us, I guess is sort of the takeaway message. And Chuck and I have been doing a lot of work to try to figure out what that means. So I say trauma was down. Organ donors from trauma were down 38% in 2024 versus 2023. And on the surface, we're like, maybe that's great news, right? If that just means that there are less people dying from traumas, then that means you guys are doing great work, and you know, there's nothing we want to do about that. But if there is a process problem, that means that we're not either getting the referrals or those patients aren't getting to the trauma centers or something, then that's information that that we need to know so we can understand where it's coming from. Does that make sense? Like, I always feel it's hard to get in front of you guys and say, where are all the donors? But just making sure that we've done everything that we can to make sure that we're getting them. So this graph real quick, again, 23, 24. It's confusing because the colors are by the biggest groups. So trauma in 23, let me try this out, was this sort of greenish one, 139 donors from trauma. In the last year in 2024, there were 86 donors from trauma, so just 19% of all of our donors. So just kind of, again, what we're looking at in our work group, and so if you hear us asking a lot of questions in the hospital, like, you know, how are referrals, what's going on, where's your volume? I know we had some conversation about ambulance referral patterns in the last couple of years, and one of the things that we're looking at is that if for whatever reason they're not getting to the big, to the ones and twos, then do we need to refocus some education and make sure we're doing more work in the 3s and 4s? Do we need to be doing EMS outreach instead? So just trying to figure out, you know, what these numbers really mean. We call this a funnel. And so this is trauma's impact. And again, I'll just kind of read it from the top, but of all of the referrals we had last year, of all of the organ referrals, we had 839 that came from trauma, which resulted in 466 on-site visits to those patients, 200 requests, 116 authorizations, and 93 donors from trauma. Again, this is in your slides, so I'm not really going to even go over this, but this represents all of the hospitals that had at least one referral that we coded as a trauma. When we pull this data from our research, we look at mechanism of death. So, excuse me, we pull gunshot wound, blunt injury, stabbing, which usually is only a couple. Is there one more I'm missing? Okay, yeah, those groups. So that's kind of the data for last year. What we really wanted to spend a few minutes on today, though, is talking about the data that you guys track. We've been working with the subcommittee to look at like what do you have to put in, what is each institution putting in, and Lynn's suggestion was that we bring it to the bigger group for a broader discussion because there's a lot of fields related to organ donation. And I hope that you guys aren't necessarily filling out every one of them, but I'm not sure that we necessarily are doing things the same, and what do we really need? So when you look at the documentation that's required for ACS, I think it's sort of hard to disseminate like how they're really going to use this data, because on the surface level, they're asking that you have an agreement with an OPO, that's us, that you have a donation policy and you have a brain death policy. So in terms of compliance, that's in the standards, that's all they say you have to have. Then like buried deep in the PI metrics, you have these two little numbers. You have referral rate and donation rate, and they define referral rate, they define donation rate as the percentage of all organ donors over referrals. And so organ donors is pretty easy to figure out, except that maybe there's some slight variation in what we consider a trauma organ donor. And then referrals, and again, we're tracking all of this, but we're tracking it based on the information that we have. So we took a look at like what is in the registry and what are they really asking you to complete? And it's all these questions. So was the referral made, which I think is a fair question. Did the patient qualify as an organ donor? I mean, I feel like I don't know that you have good information on that readily available to you, right? Without a lot of digging. Did they become a donor? Well, you know, organ donors were moving to our recovery center now, most of them. And so you may not know if that patient became a donor ultimately. We may have moved with the intention of donation and something might have happened along the way that precluded donation. Was donation requested? Was the request granted? Again, I'm not sure at that registry level how you guys get your hands on all this information. So I'm just bringing all of this to light, and I know we're not going to solve this necessarily today, but we are very interested in feedback from you guys. So my response is we do have data, and I think the tricky piece of it is the data that we have good enough for what you need, and how do we reconcile what actually constitutes a trauma patient? I think that's kind of the root of it, right? So we use those mechanisms that we just explained to pull our list. And if you say, send me a list of everybody that had, you know, one of those mechanisms of death that was referred to you, that's easy for us to do. And along with that, we can send, again, can't read all these, but it will say if donation was requested, what was the outcome, what was donated. We can pull what tissues were donated. You have the option in the registry to enter even specific tissue. So, well, heart valves recovered, was skin recovered, was bone recovered? Like, I don't think you guys need to do that, because we can get your report if you need it, and I have never heard of any ACS site visit asking those questions. I think what they're really looking at is process improvement. So for us to get together and be like, we're going to send you this report, you know, you can validate it against yours. That's the kind of process improvement coming to your PI committees. I think those are the things they're really looking for. And so again, just hope everybody can be efficient. We want to do the best we can for that. We also have some lovely graphs and reports too, so we can look at and we can sort these by those mechanisms, and then tell you in the calendar year how many referrals came from trauma, how many were your trained requesters appropriate, that sort of thing. So again, we're just sort of bringing this forward to say, we have this data, what are you guys putting in? And I think beyond just the registry, how are you using the data is the other question we really wanted to answer, right? So to categorically say we can provide you with a report, we don't want to cut anything out that's important in some other way. Is that fair enough?
Yes, this is great. That's lots of good data for facilities to have. So if a facility wanted to have this, they would just get with their hospital liaison and they would provide a report to them.
So any of those reports that I put up there, we could do specifically for your hospital, and then we can drill through them and send you the individual patients, and you can compare to kind of what you have or what you've been tracking. So everybody has a liaison. If you don't know who your liaison is, reach out to one of us, and we'll make sure that you have that information. But again, and also email us if you have any thoughts. Like if you're using your donation data for something beyond just your ACS site visit, that would be good information for us. Or if you've had a visit and they've asked you something that's sort of more granular like that, we'd like to know that too, because I haven't heard that. And again, we just don't, we want you to use your time well.
Hey, so this is Kelly. So this kind of started with the registry subcommittee.
Yeah.
LifeLink presented the same information, and the registrars were very interested in not having to dig and not having to search in all kinds of places for the information that she just went over. But again, there's a ripple effect to everything we do. So the registry is the heart of all the PI, all the stats, and I didn't feel like it was the right thing for the registry subcommittee to make the decision, because like I think about, I don't know if Tracy's on the call, but from a research perspective, I don't know what she may be looking at, not detailed granular for LifeLink, but what she may be pulling for her research that we don't understand from my perspective, or maybe Grady in Atlanta, like, you know, you saw our numbers are small, so it's nothing for me to call Danny Johnson and say, I need XYZ, but Grady, who knows how many medical patients die, plus trauma, trying to filter all of that information from your report versus gathering it real time. I just needed a bigger perspective on this, but the registrars are like, the less we have to gather, the better. So, and I don't mean that in a flippant way, but I just need everybody's perspective.
I think maybe you have to do this so that people
I'm gonna start breaking out like Shania or something. I'm just kidding. I'm just kidding. I'm Brandy Fitzgerald from Phoebe Putney, so thank you. We have a really good working relationship with our liaison as well, and I think for us, what we struggle with is that the language that we use to collect the data in the registry does not match the data on the report. So when we get the report, basically what we do is sort of like a validation. When he sends it to us, we get all patients, which is fine. But he highlights the ones that may fall into the trauma buckets. We still look at all of them anyway, but sometimes the information on the report, I have to call or I get sidetracked because I'm like, this makes no sense to me. If the language was the same on the from the registry report for what you're actually doing, I think we would understand the data better.
I think one of the challenges too is that we know that the registry is sort of temporary at this point, right? Is it a couple years maybe from being a new system going into place? Is that correct? Thought I heard that somewhere.
That's correct, Kim.
Okay. And so like that would be a logical time to go in and maybe revamp all of the questions and what you have to answer. I think from our perspective, no one is looking at a lot of those answers. So if you're spending your time as a registrar drilling all the way down to what specific tissues were recovered and that type of thing, if it's not going anywhere, they're not required fields, they're not collected at the ACS level. You just need to be able to show them that you have a relationship with the OPO and that they're providing you information about donors. The question, I think, from our perspective really becomes, how specific is it? So if we say these are the ones that we consider trauma patients, like, is that going to be good enough for ACS, or is somebody going to go in and say, oh, but here's this other guy that didn't get counted?
Okay, I want to answer that. So for us, if we have an interest in it, I'm not so much sure about the granular level, but it's interesting because we do a lot of, I guess, um, awareness for organ donation for our area. And so for us, we'd like to know. We want to know what's being donated from these patients to be able to report that out. Not as like, hey, we did this, but I think it's important. One of the things we're finding is some of the lack of referrals comes from uneducation. They don't understand. So I think the more we can spin the positive on it, like, hey, we were able to, harvest 5 hearts or whatever, then people are like, well, tell me more about that. I mean, we started the Honor Walk, which has been really successful in our facility to raise that awareness. But I think outside of the hospital walls, the community needs to understand that as well. So for us, we'd like to know what organs were donated.
And we can pull that pretty easily from a report as well. And if it means that he sends you everybody and you decide which ones were trauma patients to be the most accurate, that's fine. We're also internally in this work group that Chuck constantly is chasing after our liaisons to make sure that they're asking you guys on a monthly basis at the 1 and 2 centers anyway, to send a list of the traumas. And we cross-reference that to what we've considered trauma so we can figure out how big the difference is. It's not very big. I think last year we figured out that we actually counted a handful more than you guys did as trauma, because things can change too. I mean, patients sometimes have been there for a couple of weeks by the time they become a donor. So it's not a significant difference. We don't know though what the ripple effect is, as Lynn and Kelly were saying, like, does that matter down the road somewhere? I mean, I don't want to say like it's close enough, but maybe it is. I don't know.
Kim, this would be something for Kelly and her, maybe working with her registry group, this is Tracy, to maybe better define those from a state level, what they want to do. And Ashley, you can kind of, Bullington, you can call it whatever you want to in your registry reports to kind of help you understand what information you're getting back. But that has kind of been hard to understand, and we haven't, because of being in between, shutting down this old software, going to new software, they don't really want to put a lot of work into it. Plus, anything that we change in the registry now usually leads to a lot of other problems, and it's not high enough on the need list right now to want to possibly break other things in the software. So I think there's a opportunity there, but I think from surveyor standpoint, if you've got your basics in there, and then you can always work with your hospital liaison. So, Chuck is my second husband, but we've been kind of divorced since I've gone to research. So you guys hands off on my second husband. And but I think there's a lot of good things that can be done with organ donation. And I know Kim and Chuck will be around and they would love to talk to you about that. Jesse Gibson and Jessica Mantooth did a good paper on that and how they improved their LifeLink program that was in STN in the last couple of years. I think Kim worked with them on that article. So there's a lot that can be done. I'd be glad to talk to anybody about it, but just for the sake of time, I think we'll probably need to go on.
Yeah. Okay. First of all, Tracy, you never need an introduction. Second of all, Chuck is bitter about the divorce. And we definitely don't want to break your system again. So, yeah. So, yeah, of course, we'll move on because I think, big agenda. But please give us our feedback. We do want to take it back to Kelly's subcommittee and figure out what we can do to make it as simple as possible. But again, we wanted to vet it with a larger group to make sure we're not breaking anything else if we do pare it down.
Thank y'all. That was great information. So next on our agenda is our Georgia Trauma Commission update. Liz, Gabby?
Did you notice referrals were down, by the way? I was going to ask you. I just wrote that little
Yeah,
note.
I'm actually going to go.
Are you going to go? Okay.
I meant to pull
Awesome.
that slide as well.
Okay.
But
Okay. So it doesn't necessarily correlate. Yeah.
Okay. I've been trying to use the new state report as well. That lags.
Good thought. Okay, welcome everybody to Callaway. We haven't been here for a couple years since the ACS system console, so great to have you all here. Just a few updates, and then I will turn it over to Gabby for the wonderful work that she's doing with the PPP work group, and then Tracy will give an update. She's the spokesperson for the readiness costs assessment work group, and then Crystal has a very brief RTAC update, and we will add her to future agendas so we make sure that you all can be very plugged into what's happening in your regions with respect to your RTAC. So we're on day 19 of the legislative session. We have not done any of our reports to the House and Senate on our annual funding impact, but we have presented twice, once to the House on the AFY, or excuse me, Senate on the AFY. The AFY is sailing through pretty quickly, and we have already presented to the House on FY 2026. Now, the only thing that could potentially halt, this is a lot earlier than we normally present on the next fiscal year's budget. The only thing that could halt it is what's happening federally right now with a lot of funding being pulled back. A lot of state agencies pull down federal funds. A lot of their funds are matched to federal funds. So our funding is not federal funds, but a lot of the agencies we interact with get federal funds. So this is something to definitely keep an eye on because it could hold up the budget approval process. We hope that doesn't happen, but back in the day when there were some federal issues with budget in the past, I've been warned that has been an issue in the past. So we're proceeding very tentatively. But the good news is to report the $4 million that we got added to the budget last year from Dr. Ashley's presentation on the trauma stabilization proposal. We got an extra $4 million again this year. So great news, excellent. Yes, very big win for us. So, and I have profusely thanked all of the legislators on your behalf for their support of the trauma system, because no matter how much additional it is, every little bit helps, right? So, so fingers crossed on that, and it seems like that's going to stay in there. Tomorrow, you'll hear two presentations. One is going to be on the presentation that Dr. Ashley did at the AAST on the ACS verification drives quality. That is great data. That has been such a long longitudinal thing that you all have worked very hard for. So since everybody has come across the line with ACS verification, to see the change in what our quality outcomes look like specific to major hospital events is just stunning. So I can't wait for y'all to see that. Tomorrow the paper is published. It is available now, open access. All you have to do is Google it. We paid extra for open access because we don't want anybody to have a subscription to Journal of Trauma and Acute Care Surgery to be able to get this information, because it's great information. And we do that with all of our studies, especially around the readiness costs, because there's so much interest across the country around that. So you'll hear that tomorrow. In addition, we worked with the Coalition for National Trauma Research, also known as CENTER. Nick Medrano is the geospatial resource there, and just an amazing person. They had a consortium published a study a couple years ago now, I think, and I can get that out to the rest of the group too. I owe you two papers now, the open access one on the quality, and then this one. But they looked at a bunch of states. They looked at Maryland, Oklahoma, Connecticut, New Mexico, and one other I can't think of off the top of my head. Anyway, they did a geospatial analysis, what was different between where trauma centers were and where 911 ambulances were located. The difference with this is they plugged in an average response time for that system. So it really gave you a bird's eye view of who is truly within an hour of either ambulance or air. And it really showed some gaps. And it also was, what they did was they reran it looking at, well, where we have gaps here, could we upgrade someone from a 3 to a 2 or from a 4 to a 3? Because 4 to 3 closes that gap with having access to a trauma surgeon or orthopedic surgeon. And then, of course, going from a 3 to a 2. Now, we know that's not feasible in all those cases, but it's very good to have that kind of data. And as populations evolve, it's good to have your finger on the pulse of where the gaps are. So Nick will actually join the commission call tomorrow to present that. So stay tuned for that. I hope you'll all listen in on that. That's really good information. And then an update on our financial analysis. I want to thank you guys so much. For 16 of you turned in your finance KPI sheets. And if you haven't met these two lovely ladies in the front, I know Crystal will probably introduce them, but Courtney and Samantha are interns. We actually have interns. Yay! And they've helped me do some analysis on those sheets, but it's just such good information because especially when we're asking for additional funding, and the legislators who are physicians are very smart about billing, and they know that there's a thing called trauma activation fees. And so there's a lot of curiosity about what kind of revenues you're bringing in for trauma activation fees. Now, we're not asking anything about money. What we know and what you've demonstrated through this exercise is that it's not always possible to be successful. Just because you bill for the activation doesn't mean you're getting paid for it. So that is where the gap exists. And then when you add in that the amount of uncompensated care that you guys are delivering, that's the bigger nugget, really, when you look at that compared to what we fund you for uncompensated care. But that's not as popular when you're talking in political circles, uncompensated care. So we stay away from that because we have good data on readiness, and that's kind of, that's been our more successful sell in terms of getting support. So more to come on the evaluation of what we're going to do next with the KPIs, because I want to now turn to the claims side and find out of the ones that you actually submitted, did they check off yes? You're not even going to know, and I don't want to know, but you're probably not going to know how much you got for it, maybe unless it's an outpatient, but inpatient it's rolled into the DRG. But I'd love to know like what level of overall success you have with that so that we can quantify, okay, we're billing. One of the things that we did learn from this is that there is a significant discrepancy. Thank you, Pam, for Grady figuring this out with your 8,000 patient sample. You really threw us over the edge with that sample. That was great. But we recognize that FL14 type 5 is not recognized by Georgia Medicaid. So in working with our partners at GHA, apparently Georgia Medicaid is undergoing a software transition. They are aware of some of these issues with compliance with NUBC. So more to come on that, but they're not likely to change anything until they migrate software platforms. So you'll probably be stuck using whatever code you're using. Just unfortunately, it's not going to match for the commercial payers. And I don't know, especially with your volume, you probably don't want to split out FL14. Is it type 4?
Actually, we're having to develop our 681 under 450.
Okay. Mm-hmm.
The other issue, we actually tried submitting some claims with FL14 type 5 and found some of our payers cut our reimbursement in half when we put it in as a type 5 instead of a type 1. So our revenue team is actually looking at, yeah, I about had a stroke when I saw that. So, and that's why we submit ours as a type 1 and not as a type 5.
I just want to fall down when I hear that. But I do want, so I want your ideas, think about it, nothing now, but we can engage Val again and do another couple of webinars with her. But when you hear Tracy talk about readiness costs, like now we got to get into another readiness cost survey, because now that everybody's verified, we know not only inflation, but the cost of maintaining an ACS verified center for a level 1 and 2 will be a lot different than what it was the last survey that we did. So we want to kind of quantify those costs. So I want to I'm trying to manage all the workload. So, and it's all done by your finance folks. So, okay. Anything or any questions or anything before I turn it over to Gabby and then Tracy?
Thanks, guys.
I'm going to stay down here because I'm running the ship over on the table. So I'm Gabby, I'm the business operations manager, and I always introduce myself as the one that emails you 1,000 times a day. So it's me. We did some PBP makeover for the next fiscal year, so we're introducing this to you now, so it's not a shock when you get your June 2026 or June FY 2026 contracts. So just to review the timeline, we do have a work group of 6 stakeholders, and they've been reviewing the proposed FY 2026 PBP criteria and creating recommendations. Right now, we're in that phase of GTC committee review, so we want to put it in front of all the committees so they're aware of the changes. We are looking to do an open comment period, so that will be coming out possibly in March, so that's your opportunity to give us any feedback or ask any questions. And then after all the edits, we're going to have it reviewed by the Finance Committee, and then the Commission will do that final approval, and it will be in your contracts. And this is just the dates, just an overview of where we are right now: January, February committee review, open comment period March, and then May 15th is when we have the Commission reviewing and approving it. And then the contracts are sent out in June. And a big thank you to our work group. Thanks for their contribution and feedback. Without them, we would not know what to do, or if what we were trying to implement was crazy. And this is our group, work group members, so great representation from all levels. So we are going to be introducing tiered metrics, so we will try to sunset the all or none approach. You know, when you have a 75% meeting participation for GCTE for the TPMs, if you attended 50%, you would lose all your funding for that criteria. So now there's going to be some tiers, and it resembles MT-QUIP. So MT-QUIP's on the left, and this will look like the FY 2026 PBP for GTC on the right. And here is a tiered example for level 1 trauma program managers. You'll see the GCTE meeting participation tiers, the GQUIP meeting participation tiers, and then also National TQUIP, or PTS now for pediatric centers. We are also introducing outcome measures, and I'll hand it off to Gina because this is her baby.
Yeah, so it was time for us to kind of move into the next level outside of, you know, just meeting participation. And again, I know we talk about MT-QUIP a lot, but they've been doing this for a long time, and so we've looked at them for a model. The tiered approach is great and not an all or none, but they've been doing the process measures for pay-based performance for over 10 years now. So we looked at 2 measures to start with, and they will be tiered as well. Approach, and we're going to start with it's zero risk for that. So the 2 measures that we looked at were timely VTE prophylaxis for patients equal or greater to 16 years old with greater than 2 days length of stay and a trauma service admit, just a trauma service admit. So again, a tiered response, but there's going to be zero risk to it to start with. The threshold, the highest threshold will be 50%. And at the meeting, we're going to kind of show where everybody's at in the closed session with that. We've got some initial data, and this is going to be the next process measure that we're going to have in Arbormetrics. No frowns, Kelly, we got some discussions with the peds, don't worry about it with that. And then the timely surgical repair of hip fractures in the age equal or greater than 65 for just isolated hips. And that's really some low-hanging fruit for us. Our centers do a great job with that. So this is easy pickings, and we're going to show some data for that as well, which is already in Arbormetrics. So everybody can see where they're at with that one. So again, this is evidence-based practice. for a long time. So we want to see the highest tier of that will be equal or greater to 90% of the time they're repaired within 48 hours. So those will be the two process measures that we start with. Michigan started with VTE and not HIPS. Actually, it was their second process measure that they started with was their MTP ratios. They added HIPS a little bit later, but HIPS seemed to be, that's one of our biggest populations, and we do it well. So it seems to be a good one to start with for us, kind of like a win-win to get used to.
Some new criteria highlights you'll see is the GTC research work group. So there is a level 1 requirement for a physician to participate in a research work group. The commission did identify the need for a work group to collaborate on research efforts. There was also a recommendation to add some registry education for level 4s. So level 4 centers will have a requirement for a trauma registry professional to demonstrate evidence of one of the following courses: AIS 2015, the trauma registry course, or ICD-10 course, or if completed, demonstrate 8 hours of continuing education. And then I did send out the Excel sheet with the full level 1 through burn center breakdowns, and then it has a change log so you can see every change that we implemented for FY 2026. And this one is a little bit of a brain teaser, PVP impact cadence. So there is going to also be a change to that in FY 2026. It's going to be tracked fiscal year, July through June. Currently, we have some PVP criteria we're tracking calendar year, and that's outside your contract. So we're looking to align it to July to June. And then your FY PVP score will impact the subsequent fiscal year. So here I have the previous, where we tracked it calendar year and fiscal year. Your scorecard was due in April, and the impact was your FY 26, for example, would impact your FY 27 funding. What's going to change is we're just going to do fiscal year tracking. Your scorecard's going to be due in August, and your FY 26 score impacts your FY 28 funding. And some of the benefits for that is that now you know way in advance what your trauma center distribution is going to be, and then the tracking is aligned with the contract and start and end dates. And that's what I have. Do you guys have any questions?
I actually have one. So the reporting period for the hip fractures and VTE would be for the whole year?
Yes, it'll be for the whole year. And you'll be able to see, since, like I said, HIPs are already there, you'll be able to see quarterly, how you're doing with that. And VT, hopefully we should have that. They're finishing up the risk adjustment piece, and that'll be the next build. So hopefully in the next 3 months, but that'll be live in ArborMetrics, so you'll be able to see where that's at.
And then for GQuips, Dr. Galloway is doing a presentation on the VTE data, right?
So we'll be showing where everybody's at on that, so you'll know where you're at now, and we can, give everybody kind of a heads up of.
So we really need to be tracking it monthly, quarterly. You don't need to wait till the end of the year to
right, and that's something we can even talk about too, because one other thing that Michigan does is they submit data to their central site every other month. So if we wanted to know where you're at sooner, every other month instead of quarterly, submit that data to ArborMetrics. That's totally something that we can do, so.
Okay. Do I have any other questions?
No questions about all of that.
They were too stunned to speak.
I think it's great. I like having the specific data points to it, so I think it's good.
And we've built a few questions in the, our infamous Mentimeter at the end of GQuet, where like, we'll get a little feedback. You'll have a little time to think about it, for Friday. So just, and open comment. So, let it sink in a little bit.
But thank you. Thank you all, the work group, for all your hard work. I know that was not an easy task, but we appreciate it. Tracy, are you ready for your work group update? We can't hear you if you're talking, Tracy.
If I unmute, that would go better, right?
There you go. Yes, that
You can
works.
tell this is my informatics background. So we're going to talk about the readiness cost survey that's going to be due for this calendar year, later in the year. And it's just going forward, as Liz said, based on what we've done in the past. Next slide. So we've done surveys in the past as early as 2008 and as late as 2019 based on those year admissions. But it's been kind of hard to get our hands around. And in the later surveys, we were better able to quantify, some of the costs by using the standards, but trying to look at what does it cost to really be a program and to be ready and also to be verified, because there are a lot of costs associated with that. And most lay people don't understand that. Next slide. So the level 1 and 2 data was our first really organized, where we tried to put our arms around the standards, and we got the information for the level 1 and 2 trauma centers based on 2016 admission data, and it was published in 2017, and it was very much based on the Orange Book. This is just an example of what the front page of the readiness survey cost. There's probably a good number of you that might have been involved in this. If not, one of the reasons that we're presenting this early and trying to get buy-in is if you weren't involved in that, this is not a new process, but it might be new to you. And so we want to just kind of walk you through what we're going to do. Next slide. So this is the paper that was presented at AAST. It was a podium paper, and it was actually to a larger group, and it was talking about what it cost, what we assessed it cost to be a trauma center. So you can see there that we came up with almost $10.1 million to be a level 1 trauma center without ever treating the first patient, just to have everything that they say verification requires and then ready to take on the patient. And a level 2 cost about $4.9 million. And you can see what the most significant cost, which is not surprising, is medical staff and that call pay. And then also the lowest cost, or where we spent the lowest amount of money, was education and outreach. Next slide. I'm going to let Liz talk about Dr. Haley, and this model that we use is named after him.
Thanks, Tracy. So with the readiness cost survey that we did in 2019, or on 2019 data with the level 3 and level 4 centers, we renamed the readiness cost survey tool the Haley model. And it still makes me so sad when I look at this. Dr. Haley was one of the original commission members, and he was an emergency medicine physician at Grady. He was the medical director for a long time of the ED, and he was the associate executive dean for Emory at Grady before he left to ultimately become the CEO at UF Health in Jacksonville, Florida, where he made a tremendous impression. He really blossomed there as a senior level hospital leader, and it was a huge loss to that community. Dr. Haley lost his life tragically in a jet ski accident in 2021. So the very thing that he advocated for in the end took his life, and he worked, and Kelly, you worked on the readiness cost survey too. He was instrumental in that very first, before we did anything, as Tracy mentioned, with the standards. It was really just Kelly, would you call it like a rough and ready when you guys got together initially?
Yeah, it was. It was look at the Orange Book and let's see what we can figure out. But he was always about the patient, always.
Yes. Mhm. And he, it didn't matter, he worked hard for every trauma patient in Georgia, not just for the ones that came to Grady. So he was very much about distributing the readiness funds, and that was the task of that initial group, was to come up with some sort of methodology when the commission at its inception got the $60 million dropped on. It was, how were we gonna spread that money? So in honor of Dr. Haley, we have named the tool after him. So thanks, Tracy.
Thank you, Liz. So Liz referred to this. These are two graphs that you're going to hear Dr. Ashley present, talking about the most recent publication that will be open access, but it's kind of talking about going from bad results as a collaborative. So they printed, when they put all our data together, all the level 1s and 2s, what we looked like on the left was in 2015. And it's kind of saying, you're not really good because you don't want to see red. Red is bad. And so over the years, as we required verification of the 1s and 2s, we did so much education. We started meeting collaboratively, just going through and doing different activities. Then you look at the fall 23 results and everything is in black. Is everything at or below average? No, but it is all, in the black. So it's not considered an outlier status. And part of that is when you look at the deciles at the top, we're not always at the top like 9 and 10, which normally you might say, oh, that's a great result, but not when you're talking about complications. You don't want to have the highest complications. You want to be the other way. You want to have a lower decile. And so those deciles are very important. We still have work to do, but it's just a really exciting story to tell about, and showing how verification has helped everybody tighten up, get together, work collaboratively. I like to quote Josie a lot. It's always about the patient. How can we make the care better for the patient? And so that's what this paper will be about, that comes out and is open access, and then also what Dr. Ashley is going to present. So if you look at it, we're being very strategic in getting these readiness costs together to send to our legislature, send to the government, the state, and say, look, this is what we're spending, and look, we're doing better. We're not having as many complications. And so now we're going to say, okay, we got to update costs, because everybody knows inflation has really factored in the last 5 to 10 years. Next slide. So this is our journey kind of in a nutshell. In 2015, we had one ACS verified trauma center in Georgia, and that was North Fulton, I believe, level 2. And then 2 centers had already had consultative visits. And then you go to 19, all the level 1 and 2s have had at least consultative visits, if not verified by then. And in 23, 11 of the 15 centers are now ACS verified. So we're slowly getting to that goal of becoming all verified. Next slide. So this is what the survey is going to look like. So we've taken the older survey, and what we've done is we've tried to update it to be organized around the way the grade book standards are. So we know that we've gone from a lot of chapters to fewer sections, but the same standards, but maybe upgraded a lot. A standard's got a lot of nuances to it, a lot of requirements to it. So that's how we've updated the survey itself, and trying to figure out what is the cost. And so putting in as much narrative as we can in there, and looking at and considering what are the things that really are important to being a trauma center and to deliver that optimal timely care. Next slide. So we've got the reformatted tool, as we've talked about, and it's updated to capture the gray standard books. Next slide. So we've got a work group that's been looking at this, making sure everything's updated. then we're presenting this information to you. The survey tool is not completely ready, but it's pretty close to it. And then our next step and what our goal is sometime in March to have an intro webinar with the survey tool and kind of start talking about it, have some Q&As, and have monthly webinars to say whatever we've got questions about, we answer them together. One of the participants will be Jessica Story, who is a partner in the CPA firm Warren Averett. Is that correct? I'm saying it right, Liz?
You got
But
it.
you said that was right?
Correct.
Okay, thank you. You know, I'm Southern, so sometimes I put an extra syllable in or two, but anyway, she'll be there too. And what she did in the last survey is she looked for what we called outliers, where somebody had a cost that was unusually high for a section and that was out of the norm. And then she would check with them to see, well, what did you include in those costs? You know, just not necessarily saying you can't do it, but at the same time trying to make sure that we're all doing things pretty close to the same. And just like in PI, you're always looking at the outliers. What are the special circumstances surrounding those costs, and that it is so different, so that we can try to make sure we're measuring things as closely together as we can. Next slide. So our tentative timeline is shown here. So we're introducing this to you, to the Georgia Trauma Commission, GCTE. Then our goal is to start the introduction. I said March earlier. I might have been a little hasty in saying that, but at least by April, release the survey and start having monthly webinars, Q&A sections. And that's based on several things. You know, as we get questions, we want to share that information. You don't have to attend those monthly webinars. They are optional, but as people ask questions, sometimes that helps you think of things that you might not have thought of, how you can accomplish or measure things. But it's there to help you go through things, and we might not have thought about some things when we get questioned about it, but it's also to help you stay on track, because the survey will be due at the end of September. And we've had some people express concern about that's near the time when, you know, some conferences are coming up, you've got budget, you've got a lot of things going on. So if you can go ahead and start working on it early, then that's great. And then you can make a little bit more progress. So this slide set is being presented not only to GCTE, but it'll be presented to the administrators group. And also, I think the TMD group, is that right, Liz?
Correct. TMD group as well as administrators.
So we're hoping to have this as a team sport, and I think it's going to really be great. I worked on the first one in 2016, and we really didn't have a lot of buy-in from administrators, and that's been a big push forward and a big gain for our trauma system to have an active administrators group that are starting to understand the finance of things, and that can probably help us in figuring out some of the costs and getting us some of this information to help us put things together. Next slide. So survey preview. Next slide. So there are different sections, and as I said, they're broken up similar to what mirrors in the gray book. And I won't read them to you, but it's kind of there. So these are the things we're trying to quantify or measure cost-wise as we can to maybe reflect some of the standards in these different sections of the gray book. So this is what it might look like in the administrative commitment, program scope, and governance, you know, and talking about salaries and things like that. So it depends on your center level. It depends. We're doing ones and twos, but you know, getting the salary and benefits, figuring out how much of that person's time is committed to the program. And that's going to vary depending on your organization, your level, and your probably your system too. Next slide. Also, we've got facility and equipment. So looking at liaisons, staffing in different areas. So this is where a lot of the money comes up and that we've mentioned earlier. Also, if you've got residency programs, and that's somewhat tricky, usually those are just the level ones. Next slide. Medical personnel, where you look at some of the, I think we need another slide, please. Yes, professional staff, and looking at, there we go, different people that have to do training and education, different departments that we work with. All of this is just rolled into the different sections. So, and then last but certainly not least, the injury prevention, community outreach, and all the great work that they're doing through the RTACs and other things that the hospitals contribute to, that'll be pulled in some through this also. And that's it. And if there are any questions, Liz will be glad to answer them. I'll help, but thank you.
I got you, girl. No worries. They're quiet today, Tracy. So I think there's going to be a lot more information to come on this, obviously, especially as we roll it out. So if it's okay, if Crystal can just
Sure.
I know we're running a little bit short
That's
on time,
fine.
but I think the rest of them.
All right, there we go. I'm not typically brief, but I'll be very brief today for you. So just a couple of updates from the RTACs. First, we do have a new coordinator for Region 9. Coy Tippins is the new RTAC. He started in January. Coy is a flight medic and an educator. Very excited about his new role, so we're excited to work with him. The Region 8 position is currently open. After many years of service to the trauma system, Anita has officially retired completely. So we do expect to have a new coordinator named in that role and hopefully going in the next month or so. Tomorrow, we're going to have our first in-person RTAC chair and coordinator meeting. We're going to try and do that annually moving forward. As you'll hear kind of over the next couple of days, we've got some really great work that's going on with the RTACs right now, and we really want an opportunity for more collaboration across the state. If one coordinator is designing a program, we really want to make sure that that's available for everybody to use and that they're kind of not in silos anymore. We know that the regions are unique in their needs specifically, and we've got a couple of projects that are ongoing to help kind of accommodate those needs and really identify what they are. The first is we've been working with Gina and GQuip to identify some data that's going to be reported out to the RTACs quarterly so that they can start to measure and monitor some of the programs that they're creating around those issues. The other is the educational needs assessment. That was a really big project for us to take on this year, and we're very proud that we had over 1,200 responses from EMS providers, EMS leadership, and then hospitals. So certainly appreciate anybody who completed that. We'll be bugging you about that again next year. But the information that we're getting is something, to my knowledge, we haven't really asked for out of the state in the past, which is, what do you perceive as your deficiencies? Where can we help? What's your ideal model of education? Is that online? Is it webinars? Is it a podcast? Is this in-person training? What does that look like? And now we can take that back to our RTACs and really start to design education that's beneficial to our regions, and it's the type of education that they want access to. Let's see. So we're going to talk a lot about that tomorrow and work towards what their ask is going to be basically from their regions. The Stop the Bleed project continues. Very proud that we're still at 99% of our schools that have kits and training that's available. We're up to 95% for our school buses. A lot of that work was done in Region 8 with Anita and Alan Owens. So great success there. And 60% of Georgia counties have been impacted now with the expanded project. So that's our law enforcement partners, public parks, rec departments, you name it. So that's not all encompassing, but the fact that 60% of counties have received impact is a great one. So I've talked about the regional data. If you're not involved in your RTAC currently, reach out to me. I'd love to put you in contact with your coordinator. Tons of success over the last year from the impact that these committees are having. And certainly that's a lot of the RTAC coordinator efforts. We have 2 coordinators here today and really appreciate all the work that they're doing. And then lastly, I'll bring up our UGA Masters of Public Health interns. We've got Samantha and Courtney that are in their final semester. They have been instrumental in helping to digest these 1,200 responses from our educational needs assessment. So again, we'll be hearing a lot more about the research that they've done, but we appreciate everything and y'all participating. And that's my very brief update.
Very good, thank you. We'll make sure we add you to the agenda moving forward. Thank you. All right, next up is our OTCP report update with Marie and OEMST update with Stacy.
Okay, now we're cooking. All right, so thank you everybody for being here today, and I'm going to give you a little summary on the status of the OTCPEs and the OBCPE. First of all, thank you everybody for submitting your OTCPE timely. 100% of the centers submitted timely, and regarding the downloads, 100% of the centers submitted their downloads to the Office of EMS and Trauma's image trend system timely. Regarding the record closure rate, the average record closure rate is 93%. So that means that you met the 80% standard there. The level 4s have a little bit of room to improve there. So if you have any questions, level 4s, just reach out to us. Regarding the trauma surgeon arrival stat that's reported in the OTCPE, 93% of the centers average met the standard. And on that one, the level 2s have a little bit of room to improve. The next thing is the Q3 fiscal year 25 report will open March 15th. It's due April 15th and will close April 30th. And I want to thank everybody, all the TPMs, for prompting your TMDs to sign those TMD attestations so quickly so that we can move forward with our feedback. And I encourage everybody to check your feedback, log back into the LMS system and see the feedback that I'm posting and that Stacy is posting for you. And that's all. Turned over to Stacy. Any questions? Okay.
Good afternoon, everybody. Just some updates from the Office of EMS and Trauma with the trauma side. Just to recap, 2024, we did 5 level 4 consults for verification or designation, and 3 centers were designated in 2024. There's a typo for the 2025, but overall for the state, 10 centers were designated either through ACS or through DPH designation for 2024. Upcoming events, we are open to schedule more consults. So we kind of do an in-person consult. If you would like, we can roll it out like ACS agenda style, or we can do it more relaxed. It depends on your center, and help you get prepared for designation or verification. So if you would like to schedule a consult, reach out to me. We can also do it virtual if that works better for your center. So let me know if we can get you on the schedule for 2025. We have 3 centers to be redesignated this year for level 4s in 2025. And we're excited that we have 2 facilities in Region 9 that are wanting to be designated. If y'all know, that's kind of our trauma desert in the state. So we're excited to get 2 centers down there.
One of them has capabilities to move up to level 3. So we're hoping that this center can be successful and bring us some trauma designation down there in the south. The last quarter, we've had some visits that happened last month, but that'll be on our next meeting. But last quarter, Morgan Medical Center was redesignated as a level 4, and Grady Byrne received their ABA verification. So congrats to y'all. And then other events, as we know, ACS is rolling out level 4 standards. This, hopefully we're supposed to hear the public comment in March. And so we can kind of see what those new level 4 standards look like. And then we will be seeing if we can implement that and how we're going to roll that out in the next year to keep the level 4s up to date. And for Office of EMS and Trauma, we have our cardiovascular EC3 conference. It's March 14th, if you would like to check into registering for that with the cardiovascular education. The last topic I just want to throw out there for those that are getting ACS verified this year, they're focusing on your geriatric protocols, policies, any kind of geriatric metrics in your activation criteria. If you have any questions, I can kind of let you know what we've seen, but they are wanting to focus more on your injured older adult and how you're doing the care and policies for them.
Thank you, Stacy, for that update. So moving on, Cheryl from the Trauma Foundation.
Good afternoon. Wanted to provide you all with a little bit of information on some things that we've had going on and some things that are coming up in the immediate future. If I can see this report, then I'll be doing well. I'm getting older. As you all know, the foundation had opened up a period where you could apply for some grants, and wanted you to know that those winners will be announced tomorrow at the Georgia Trauma Commission meeting. There are going to be 8 grants awarded. Each award could be for as much as $10,000. There are some exciting projects that we'll be able to tell you about, so we're looking forward to making that announcement. Trauma Awareness Day is coming back. We have not had it for several years, but we will be back under the Gold Dome next Wednesday, February 26th. Thanks to those of you who did register. We won't have an ask this year for the legislators, but we do want to tell them thank you. We want to say thank you for your past support and encourage them to support trauma care in the future. If you registered, an e-letter went out to you yesterday with information on the day. If you did not see it in your email, please check your junk mail for that so that you'll have the details. If for some reason you still don't see it, then please give me a call. Just want to remind you, as far as attire, if a white coat is part of your daily routine, wear that. If not, we are encouraging you to wear an item of red clothing, if you can. Our next big statewide fundraiser is coming up. Last year, you'll remember we were at Portia. This year, we will be at the Georgia Aquarium for Tides of Change in Trauma Care. That's going to be on May the 17th. Tickets will go on sale this Monday, and they're $175 each. We're asking you to help us spread the word. And we also hope to see you there so that you can have a good time with us. It's always a lot of fun and for a good cause. This year, the primary project we'll be raising money for is mobile sim labs. And that is all I have. If you all have some questions, please let me know. Happy to answer them.
Thank you, Cheryl. Gina for GQuip.
Right. I'll keep it short because y'all are going to hear enough from me on Friday. But we have our winter meeting on Friday. We have a packed agenda and a long day, so looking forward to that. We are working on the arborimetrics. The next project is the risk adjustment that is moving along very nicely, and we hope to have that implemented at the end of February, which is next week. Can you believe that? Looks like we will have the mock-ups done, so we hope that will be going live very soon. As I mentioned, the next process measure build will be the VTE process measure, and we will start work on that. I'm not gonna, I'll save an announcement that we have for Friday. I'll let Dr. Ashley have that thunder on Friday morning and not do it here. Remember your data downloads are coming up. Due date for the last quarter of 2024 is March 3rd, so that is fast approaching. So remember to do your entire year of 2024 to make sure you capture any records that you may have changed or added for the year, so we can get that uploaded to arborimetrics and close out your year for 2024. And I said we've been in meeting agenda mode here for the last few weeks, so happy to take any questions.
No questions? Let's save them all for Friday. All right, thank you, Gina. So now we'll move on to our subcommittee reports. Julie Freeman, are you on the line for your education report?
I'm here.
Okay.
All right. Good afternoon, everybody. I'm Julie Freeman. Excited to be the chair of the education subcommittee for this 2025 year. Just a few brief updates. We're working on currently, since it's our first month of meeting, determining as a group what our goals will be in line with the GCTE large group goals in propelling education. A couple of efforts that will continue on from the 24 year. Two things, we were in discussion about hopefully acquiring the STN course modules for trauma centers. It's a platform where they can be reproducible, but also customized per center. So it would be a really amazing resource for all level centers and all sort of levels of trauma care. So we'll be working together and with Lynn in moving that goal forward, hopefully. In addition, we'll continue our efforts with Cheryl, hoping to revamp them a bit, but alongside the Georgia Trauma Foundation with increasing our rural education efforts and providing a specifically targeted education to rural areas. Lastly, I believe, hopefully it's up in the room, but we do have an opportunity, new year, sort of new us. We're hoping to gain some more participation. We've had, of course, some new faces pop in and out over the last year, which is very exciting. We have a decent but very dedicated group, and this would be a great opportunity for anyone that's interested to reach out to me, and we'd love to see you. Our next meeting will be, it's always the first Tuesday of the month at 11 a.m. So it'll be next March 4th on Tuesday. So if you have any interest, I will also put my email in the chat. Please directly reach out. We would love to have you, and we're looking forward to coming up with some good goals for the year.
Thank you, Julie. That's the QR code if everybody, if you're interested in joining the education subcommittee, if you could just click on that and fill out your information to send to Julie. And the STN modules that she was talking about, if you're new, we talked about them at our last meeting. That is one of the asks that we will have tomorrow for the commission is to purchase those for each designated or verified trauma center. They'll do an MOU with the education subcommittee like we did with the STM education modules in the past. So excited about that.
May I just add also that we still do have access to the STN e-library, the education modules. It's like 18 modules that are available, and they have pre-tests and post-tests. They're really quite good. And so if any center still needs access to that, Julie can help you. They're a little, it's a large file, so it's very hard to send electronically. So I've had to actually put them onto thumb drives and mail them to people, or hand them to them in person. So but Julie can help you with that, or you can reach out to me and I can help you with that too. I have the MOU that you need to sign for that. So thank you.
Okay, thank you, Julie. Pediatric Subcommittee, Kelly.
Hi, good afternoon, everyone. Education is still being offered to any center or EMS agency who is interested on anything SIPA. We can get you hooked up. Pediatric transfers, we're collecting some data on pediatric transfers in preparation for a pediatric transfer toolkit. And it seems so far like linear skull fractures might be a low-hanging fruit. It's the majority of patients that the pediatric centers are getting transferred in and are getting discharged from the emergency department. Unfortunately, some of these kids are getting transferred a lot of miles. So it's a good reason to get this pediatric transfer toolkit out as fast as possible. CHOA is getting ready to start the MATIC 2 study in about 2 weeks. So that's a whole blood study. And I know we were in touch with Grady EMS because they are carrying whole blood now. More to come on whole blood in pediatric patients. It's very exciting for the state of Georgia to be involved in such an international study. QR code has gone out for EMS safe transport, and I am collecting the data. So if you haven't gotten that QR code to scan, if you see an EMS agency bring a pediatric patient to your center that is improperly restrained, you just scan the QR code and put the data into the REDCap tool. It's really important that we get some data from some of these rural areas so we know where to focus our education. Education PowerPoint has been completed and is approved, so we are ready to go out and educate any EMS agency that you feel needs some education on pediatric safe transport. We started looking again at data on pan scans or over-radiating children, and we feel like it's probably time to update the radiology toolkit. And we are in the process of making any updates to that might be needed. And our hope is to redistribute that toolkit this year and collect data on that again for the next year or two. We're seeing a lot of kids being pan scanned, so I think we're on a slippery slope backwards. So it's time to redistribute that toolkit. So any questions for me about the pediatric subcommittee? All right, thanks.
Lynn?
Yes.
Can you hear me?
Yes.
Would this be a good time, and forgive me, Kelly, for not prepping you for this, but would this be a good time to ask if we thought it might be beneficial to the group to maybe start asking if Marie, if it's not too arduous for her, to maybe start collecting the names of our peach champs for our facilities so that Kelly's subcommittee, our state EMSC subcommittee, and our facilities can start interacting a little bit more and collaborating more with their peach champs. Would that be a difficult ask, helpful ask, those types of things? We do know that in terms of EMS peach champs, those are captured with the Office of EMS license management system. So those are relatively easily to obtain from your regional EMS for Children's chair, but there is no current repository, statewide repository, at least that we know of, for hospital PEDS champs.
So you're asking if someone would own that, sending out to all the hospitals in Georgia to see who their pediatric champion person is? Is that your ask?
I don't know that we need to ask for all the hospitals, but I think a good first start may just be capturing our own, so that they can be collaborating.
Yes.
Sorry. We do have a list of all the pediatric champion for the hospitals that have.
I'm sorry, Lynn, and I wasn't very sure who was speaking, saying that there already is a list. If there is a list, I will say that maybe if it could be shared with Samantha Sinvalar, because she didn't realize that there was a list being. We actually spoke about it at their last statewide EMS for Children's meeting and the regional chairs meeting this past week.
Yeah, April Moss was saying that there is a list, so we'll get y'all connected.
Okay.
Their question was, the EMC, Chris was asking for a list of all the pediatric champions for the facilities, but April said there is a list, so she would get that to Crystal. All right.
And that list would probably be helpful for my subcommittee to have as well. Thanks.
Okay, moving on. Raymond for process improvement.
Good afternoon, everybody. PI subcommittee still we were working on our time to definitive care. We kind of are at a standstill on that, waiting for kind of coordination with the state's time to definitive care work group as well. We had sent out a survey to get everybody's take on definitions for emergent and urgent transfers, and got a decent amount of replies back for that. We received an update from the time to definitive care group during our meeting, reviewed our updated trauma field criteria and discussed the differences in the old and the new. We made a recommendation to GCTE to have definitions in place for emergent and urgent and timeframes for consistency across the state. And we'll await the decision for this to move forward with anything else on this initiative. We brought forth a new initiative to create a PI playbook on verification and re-verification for centers that have already gone through, to share things that worked really well for them, things they learned during their verification, to kind of help us all be successful. We did ask for people to share things. As of today, I still don't have anything from anybody. So if anybody has gone through it, if you'd please send your stuff to me or to Ashley, who's the co-chair. So we'll compile those things. I did share some resources, a PRQ checklist, an education and credentialing sheet, and a PI dashboard that I got from a webinar that I did, and we are actually using it at our facility for our re-verification, and it has worked out really well because everybody that's involved can look and see where we're at, where we need to go, what else we need. It's just some helpful tools to do that piece of it. And then hopefully we'll have our next meeting in the next few weeks. Ashley had brought up a good one for us to do as well, as a PI playbook to help people in the PI role or anybody interacting with the PI role to be able to do things kind of consistently and help people learn the roles if they're new. So that'll be something that we'll present at our next meeting as well. And that's it.
The tools that you said you shared, could you put that on the Georgia Trauma Foundation resource library? for everybody?
That's what we want to do.
Oh, it
We have
is
to
on
build
there.
it. No.
Oh,
We've
they said
asked
you
for people
shared it.
to give stuff so we
Oh,
can
my
build
bad.
it, and
Okay, gotcha now.
and we still haven't received stuff other than those 3 documents that I
So
gave.
you're waiting to get that?
So I'm just
Okay.
waiting for people to share it as they go through things and they're successful, things that worked well for you, things you learned.
During the process.
To make it easier.
Okay.
To share those things, and we'll then put it together and put it up on the resource page.
Okay, all right, thank you. All right, Kelly, registry?
Okay, so the registry committee met the end of January, and there was a lot of support, and the registry education course that was the AIS update for 2015 was a virtual online course that registrars could do. It was funded through the commission. They attended October through December. It went really well, and there was a lot of positive feedback from that. So we, of course, the next question was, what are we going to do now? Like, what are we going to do next? So that is going to be a recommendation we're going to make for this group to GCTE, is to ask for, it's going to be approximately $60,000 for the ICD-10 course for about 95 registrars, which is what, we had 95 slots for the AIS course. So we're just going to use that same number for now for the ICD-10. I had conversations after the meeting about the basic class versus the refresher or the advanced class. The costs are about the same. So I think that's the devil's in the details, and we can work that part out later. But for now, when you take that same number of 95 and you multiply it out by the cost of the class, if we ask for $60,000, we should be covered. So you'll hear that tomorrow. I'm making the motion now for GCTE to ask for the $60,000 for ICD-10 training, whether it be advanced or basic. So that's one thing. Do we vote on that? What do we do? I would like to make the motion.
Do we have a second?
So now we vote. Any?
Yeah.
Second.
Okay.
All in favor? Any opposed? Yeah. Okay, very quiet.
All right, so that's one thing. The other issue that we covered, I had several questions about registry orientation and how different people handled their registrars and training of the registrars. So I put that out to the group prior to the meeting and summarized all the feedback that we received into the PowerPoint that was in the January meeting. One thing I do with all these PowerPoints, they're out on Basecamp, and Gina, I think, has given access to all the trauma program managers, so you can go out there and look. But everyone does it differently. It's usually 6 to 12 weeks, and depending on your what your needs are, you can see how each week is defined out. That's just something that's out there as a resource. The other thing we talked about was the transition that started January 1, 2025 from AIS 2008 to 2015. There was a glitch initially with some on having to do some changes in the background with the ESO to transition your system so that you could toggle between 2024 patients and 2025 patients. But I think all of that has since been worked out. The other two things that have come up that I'll bring here, but I've already shared with our registry group after our meeting, there was an ITDX mapping error that occurred for some people. I put that out to the group. It seems that this was also just an ESO issue, and ESO put out a blanket response to everyone, but I did not hear any other feedback. That I think all of that was fixed. We also had the center that had the problem sent back what the solution was. We shared all of that. So I don't think there's any more issues there. The other, here with all of us working on our uploads, in the last several days, I've gotten emails about a vendor aggregator error, and it seems to be specific to the alcohol comorbidity. So Justin, I know you're on the phone. He's the one that first found this problem. Some centers, we've kind of put out to some key centers, are you having this problem? Are you not in your uploads? And I'm getting feedback from most people that they don't, but Colleen was nice enough to share a workaround. And it's odd because it's an alcohol comorbidity, and it tells you that you cannot have a comorbidity for a patient aged less than 15, but these patients are not pediatric, they're adults. So, Justin, are you on the phone?
I am.
Do you have any update from ESO on that?
None so far.
Okay. If you're having that problem, Colleen had a workaround that Justin, I know you tried and it worked. I can send that out, but I did not want to send that out as a blanket without explaining to people why I'm sending it out. But it's a specific message, it's a type 2 error, and the rule ID is 16104. So, and it's coming up for pre-existing conditions. So I'll send out what Colleen's workaround is. So if you're having that problem when you do your uploads, her workaround seems to fix it. And other than that, that's all I have for now.
Thank you, Kelly. Crystal, Andro Prevention.
Good afternoon, everybody. We've had a great couple months. Hope you have too. Everybody's been very, very busy. We kicked off the year with another Stop the Bleed blitz. I want to thank everybody that kind of helped jump in and teach some of those webinars. It just is always a lot of fun to teach with so many of y'all, so thank you for that. We had a total of 525 post-course evaluations this time, and I think we onboarded about 30 new instructors for that program. So again, thank those that helped stand in those virtual classrooms to deliver that education. We're working on a number of things. One of the things that we've done over the past 2 meetings is basically just brainstorm some needs, our bucket list items that perhaps we can use some more resources on. There's not a lot of stuff out there, stuff that we can use as shared resources. Of course, one of the things that's come up more recently is ATV safety. Most of the things were pitched were relative or specific to our springtime, getting ready for the spring and the summer. And so just be on the lookout for things that are coming out in the coming months. Our fall prevention task force also is going to host a matter of balance coaches training. I know many of you have those, but also know that some of you maybe are like me and need a little refresher. Some of you are new and would like to get involved in that. It will be in Macon. Nicole with the Middle Georgia Regional Commission is going to be our master trainer for that, and it'll be a whole day. We'll have lunch brought in. We are trying to make it where we can have some hybrid participation, but just remember that particular course involves some teach back. So we're not exactly sure we'll be able to accommodate virtual teach backs that day. So we may have to work on that some other way. But just know we're thinking about being able to have virtual participation. We hope everybody comes in person. There will be more resources available to give away. I know we have about 200 A Matter of Balance books that we were trying to box up and get ready for that class, so that literally you can go home after taking the class and at least have those tangibles available to begin right away. We're also looking ahead to the Georgia Stay Safe Week, which will be the first week of summer. We've got our activity books. I'm working real hard to see if I can't get some of them there tomorrow. I only had really one request for books that came in. So Rachel, if you're there, hoping we'll be able to get you your books tomorrow. And also Badge Buddies, we weren't able to get them printed in time for tomorrow's meeting, but we hope to have them available at least by the time we have our Matter of Balance program or even our PEDS trauma symposium that's coming up in Central Georgia, if you can grab those. But we're happy to send all of those resources out to everybody electronic. Everything that we do is belongs to you as much as it belongs to me. So if you want those resources electronically, just ask and we'll send them out. Many of them can be found at the www.preventtraumageorgia.org. We're going to be migrating those materials again into the repository that Cheryl's built, and also in the future to kind of its own page. So just know that that may be happening in the coming months. So if you see things moving around on you, that's happening with a reason, for a reason. And Lynn, I don't know if I'm missing anything, but I think that's everything. It's still a little cold for some folks, so your prevent hypothermia resources are also still out there. If anybody needs to kind of get that word out.
All right. Thank you, Crystal. So now we'll move on to our new business. So we're continuing our standard review, but we are doing a little bit different. Instead of us that's here talking about it, we're going to start tagging people out in the audience to come and share how you meet these standards, because I know everybody has a different process. There's no one right way as long as we're meeting it. So we just thought it'd be great to have other people share. So our first one is the 3.1 operating room availability, and we've asked Emily from Valdosta to share how they meet this standard. I saw her. Oh, there she is.
Good afternoon. So the way we meet this standard, we had a little bit of challenges with this in the beginning. We are a level 3 center, and I think pretty standard for everybody that has a callback team is that they have to be within the house within 30 minutes of being called. And the standard says that the operating room has to be ready within 30 minutes. So we did have some challenges with this initially, basically just the way that we track it. And so we did work very closely with our house supervisors and the ones that would be responsible for calling the callback team in. So they keep forms and they write those times down, but in the process of all this, when we first started our trauma designation, we actually installed Epic computers and badge readers outside of our trauma bays. And so really our process now is that our OR team will come in through our emergency room, the first person there, and they will badge in, and then the other personnel that are coming in to set up the room will go straight to the operating room and start setting up, and that nurse comes in and actually gets a report from our staff when they're there badging in. We also did some other things to try to cut back on some time that it takes to get our OR ready. Our OR director, we made several carts, so basically it's by mechanism of injury. So if we're having an open abdomen for a trauma, that cart is ready. They're not having to go to a bunch of different rooms and pull all those supplies down. But I think we're probably a little unique for level 3s in that we have a lot of subspecialties, and just over the course of the last 3 years, we've actually added some overnight teams from our OR. It's not a full team, but it's a nurse and a circulator, and then we always have anesthesia in the house, at least a CRNA in the house for just other things for OB, and then our other cardiac and vascular surgery program that we have there. And we are continuing to add to that. So eventually we will have 7-day a week, 24-hour a day, some type of coverage in the hospital. It may not be a full team, but we will have somebody there. So basically your OR would always be covered. And we do meet this standard. We have very few fallouts now since we've added the extra staff. But we still, sometimes our documentation can be a little skewed if everybody's real busy and they forget times and stuff like that. But we have backup plans where we look at clock-in times on our timekeeping system and things like that.
That's great. You're very lucky to have all that.
We are.
So for us, for level 3, we don't have in-house anything for our OR. They're all callbacks. So the way we do it is, like you said, or mentioned first, was our house supervisor that keeps a logbook. And they put the times, and then we verify with the clock-in times of the OR crew. That's how we get back our callback times. But one thing, we're up for our ACS re-verification in August, so we've been going through some mock surveys, and we had one a couple of weeks ago where a physician surveyor explained that process, and he wanted to see the callback log. He actually wanted to see a log. So that is a measure of compliance, is seeing the actual callback log. So if you have that, if you don't have in-house ORs, just make sure you have those readily available. Thank you, Emily. Kendra, for the additional operating room.
So for the additional operating, 3.2 is the additional operating room ability, and that applies to the level 1, level 2, and then the pediatric level 1 and level 2 centers. That basically says that in all level 1 and level 2 centers, if the first OR is occupied, there has to be an additional OR that is available and staffed. So the measures of compliance for that are OR policies that relate with related materials outlining the process, the staffing, and the expectations regarding preparation of that OR, both during normal hours and after hours. So, so for the adult side, I know that they have a really tight process. They have people in-house all of the time. For our pediatric center, we do not have a 24/7 OR, but what we do have an after-hours OR process that is kind of covered by that. So we have the algorithm, we have the tracking of that, we have all of that information, and then if there is an additional OR that's required, that then we just follow the adult side for that and just make that happen. So, does anybody else have another?
Does anybody else have anything different they'd like to share? We're all good. I'm not sure. Okay, so our second one that was going to review is the 4.7, the ED physician requirements. This is a type 2, and it applies to level 1, 2, 3, and the pediatric level 1 and 2. This just making sure all your emergency medicine physicians involved in trauma patients are currently board certified or board eligible or have their approved through the alternate pathway. So for level 1 and 2 centers, the physicians must be board certified or board eligible in emergency medicine or pediatric emergency medicine. In level 1 pediatric trauma centers, at least one physician must be board certified or board eligible in pediatric emergency medicine. For our level 3s, what's different for that is they have to be certified, board certified in something. It doesn't necessarily have to be emergency medicine. They can be board certified in family medicine, but they have to be current in ATLS. So for your board certified emergency medicine, they have to have at least have had ATLS at least once. And then non-EM board, then they have to be current. So like I said earlier, we're going through some mock surveys and I was always under the impression that if you're EM board certified, you've had ATLS sometime, well, that's not true. We have one physician that he is EM board certified in 2018 and he has never had ATLS. So that came out by these measures of compliance showing copies of your ATLS cards and he is board, but he didn't have a copy of his ATLS, so that's how that. So it's a lot of time consuming. It's a lot of, can be a burden, but it's very beneficial because you don't want to come on, the day of your survey and the survey say, oh, well, let me see Dr. So-and-so's ATLS card. And to find out but anyway, that's been remedied as of now, but just it's a FYI because I was always under the impression that if they're EM board certified, they've had ATLS. And all of our physicians, our medical directors, they were surprised as well because I always thought if you went through a residency through EM that you've had ATLS, but it's not necessarily the truth. So just make sure those measures of compliance are very important, that you have proof and can show that they have that. Anybody else have anything different on the EM?
No, I just wanted to say that it's really tough to corral physicians and get ATLS cards from them. So if you know an ATLS course director, you can phone a friend. It's a much easier way to go.
How many ATLS?
She asked how many ATLS coordinators do we have?
Whoever's gathering the book for verification, that may be something that we put who the course coordinators are. So if someone is having that challenge, a coordinator can look that up a little bit more quickly than chasing down a physician.
Correct, yes. That would be very helpful, I think. Thank you. Any other comments about any of those? Okay. We are back on track. So does anybody have any shared experiences, celebrations, any recent verification surveys that they would like to share? He's got the mic right behind you, Chris.
Thank you, Lynn. Christopher Ruiz, Vice President of Trauma Services at Doctors Hospital. Just first want to thank this panel right here, my team. Strong work for the survey that we went through. As you know, a lot of work and effort comes together to put a survey together, and having the collaboration in this room to share the experiences and identify opportunities for improvement for us all are pretty important. So I didn't come with a speech, but I guess I have some paperwork in my pocket. So I'll go through some. I did. And I'd like to thank Regina Madero. She was my preceptor for my MSN program. That occurred actually during the time of our survey, so thank you, Regina. All right, so as I get back to our script here, some opportunities for improvement that they identified for us. A lot of whole blood use. Some conversation that came up today, especially with, I guess, the pediatric conversation with CHOA, using some whole blood. So with our level 1 carrying whole blood and some of our flight teams also carrying whole blood. We currently do not do that, but that's something that our TMD, Dr. Pettiford, is going to look into with our blood bank and our administrators. So I think that's a good opportunity for us. Other stuff that we got identified with our advancement of our program and just our volume boost, we went up about 17% in the past 2 years. So we're about 2,400 patients. Initially, when I started the program, we were about 1,600. So we contribute a lot of that to our community outreach, injury prevention needs, getting out and supporting our community. So with that growth, obviously there's growth holistically within the program that they identified. Some of that is with trauma surgeon coverage, registry coverage, and PI coverage. So we're in conversations with that and kind of budget and strategy to increase the FTE allocation that we have. Some things that Ms. Stacy did bring up that was affected by us is our geriatric criteria. So that was pretty significant. We had our head strike criteria for our consult levels for anybody over the age of 65 with anticoagulation with a sign of injury. They would be considered a head strike, and if there was any other concomitant injuries there, they would be moved up to a level 2 or a level 1. With their recommendations, they were pretty specific, not only of your geriatric liaison's involvement, and we incorporated excuse me, our geriatric liaison in our policy approval. So that was specifically on there that we could share with them. And exactly what was in the gray book of what they should be providing is in our policy as well. But specifically to our activation criteria, they stated any systolic blood pressure less than 110 should actually be a level 1 criteria, and heart rate less than 90. So we thought that was pretty significant, and we know that there's going to be some challenges in our hospital, especially with some potential artificial over triage. So we're going to pilot this to identify that opportunity, and then we'll be able to modify it from there. Let's see here. We got some strengths with our PIPS performance and opportunities there. One thing is we just got to be a little bit more critical on ourselves. Sometimes, especially with our mortalities, there's not opportunities that are identified. We got to shake that tree a little bit and kind of see where we could do better internally. And that's pretty much in our own house. So we're in the midst of doing that with our M&M process and then escalating it to peer review and our quaternary review, whether it's involved in another hospital system or our quality department, to really have some other eyes on our opportunities to see if they could identify anything else. But overall, the survey went really well. Obviously, it was an electronic format. We used 4 different computer setups that we kind of used a Star Trek method and teleported to the different areas. And we already measured out the areas from one distance to another, so we were able to articulate that during the call, as well as any kind of service interruptions that they might see. So they appreciated that. That's some feedback.
Thank you. Congratulations on a very successful survey.
Two comments online. Nikki from Advent Health, Redmond, is asking how everyone tracks their anesthesia arrival time in. They just went through their survey last week, and that was the one thing that they really focused on, so. I guess, Nikki, if you can clarify in the chat, this is if the team is home and they're being called back in. Some of you don't have that issue because you have anesthesia in-house 24/7. And since Redmond is a level 3, I'm assuming.
Yeah,
So.
yeah. So
Oh, Lynn, that would. Yeah.
the house supervisor tracks that for us whenever they call them in. Whenever they're in at the bedside, they contact the house supervisor. Does that happen 100% of the time? No. But we, most of the time, we don't have it happen often that our ORs call back for emergent trauma surgery, so we just make sure we talk to the circulators, the scrub techs. They help identify when they're actually at the bedside as well. But no, we don't have a true process for that. I don't know if anybody else does.
You mean for ours, and Mary Beth, I know you're on the phone, but because she tracks this, when we just had our consult visit in September, they were complimentary, but this is her baby, not mine. She keeps an Excel spreadsheet, and the OR team is notified through Everbridge. So you've got the time that it goes out, and then we'll use the badge system to capture.
I just have a quick question about that. Especially for the level 3 and 4 centers, do you have anesthesia as part of especially your high-level activation notifications? Or do they not? Yeah, that may not be practical for you guys like it is for the higher levels, so.
And then I think, Tracy, I see you have your hand up. If you got a question or comment, if you want to chime in.
Just a comment. I just wanted to recognize Josie Fabico-Doolan, who's the new director of trauma services. And kudos to her for taking on this project. And just to let you know, a shameless plug, that we have the trauma program manager and trauma program specialist positions open since I'm now doing research. So that's it.
Josie's got her head in her hands and is like,
like that emoji, like I'm so embarrassed by my parent.
Exactly.
All right, anybody else have any celebrations or anything they want to share? All right, we got 1 minute to spare. Can I get a motion to adjourn? Second. Thank you. Thank you all for coming. Thank you for calling in. I think it's been a great meeting. We appreciate your participation.